Okay, thank you for joining this fourth webinar arranged by the ERA-EDTA on COVID-19 entitled Notes from ICU, NephJC and GlomCon. So my name is Kate Stevens, I'm a nephrologist from the UK. And just before we start, some brief housekeeping. Could you please make sure your microphone is on mute when you're not talking? We're very happy for this to be interactive, so feel free to type comments or questions into the Q&A function and we can put them to our panel. The sessions are recorded, so if your colleagues are not able to join us live, they can be watched afterwards on our ERA-EDTA website and also on YouTube. I'm excited about today. We have a really great lineup for you. So kicking off with Prof. Swapnil Hiramath, who many of you will know as the co-creator of NephJC, the online Twitter-based journal club, and he's going to share with us the Canadian COVID story and also NephJC COVID resources. So over to you, Swap.
Thanks, Kate, for having me and the ERA-EDTA community. Just give me a sec. Oh, I have to grant some preferences. Just give me 1 second. Can you see my screen now? Perfect. In the next 10 minutes or so, I will quickly talk about the NephJC experience, and we can take some questions at the end. In terms of disclosures, I don't have any financial conflicts, but the NephJC is a non-profit which is registered in the USA. And I work as, I'm the vice president, Joel Toff is the president, but we don't get any remuneration for the same, it's just voluntary positions. The Canadian COVID story begins, we had our first case in early January, but it took a while until we started to shut down, which was sort of in the middle of March. It's been about a month now since we have some kind of a partial shutdown or a complete shutdown throughout the country. Again, provinces have done their own way of doing things. So it's been a slightly different story everywhere. But this is the data so far as of late yesterday evening. That we have just had just over 1,000 deaths so far in Canada with over 30,000 cases. Right now, I'm not sure the curve is flattening. We are all hopeful that the curve is flattening in Canada, but we are still having a slow and steady growth in cases as well as deaths. In fact, yesterday was the worst day with 183 deaths. The story seems to be changing, and now most of the cases and most of the deaths especially are happening in the long-term care facilities and the nursing homes. There is a lot of concern in our community that is where the story is evolving. Unfortunately, that's our most vulnerable community, and as others have pointed, these nursing homes are sort of like cruise ships where the residents there are locked inside, but once the infection is introduced, it just spreads like wildfire. We hope this changes, but all our fingers are crossed. As the other community apart from Canada that I belong to is that of Twitter. As Kate mentioned, I spend a lot of my time on Twitter, and the wonderful thing about Twitter is that it gives priority to people's ideas. Other social media is about personal life and updates, but Twitter is really rich. It brings together people who have similar ideas and concepts and thinking. So Joel and I started, just for a quick introduction to what NephJC is. Joel and I started NephJC just over 6 years ago in March of 2014. As an aside, we didn't meet in person until about 6 months later. So this was started virtually by us knowing each other on Twitter. And now, of course, there's more than 40 people who are involved in NephJC. NephJC is a journal club, so when we discuss an article, for example, this was the article we discussed 2 weeks ago on the role of tacrolimus versus steroids for minimal change. We have a blog post summary, then we actually have a Twitter chat, and we have a newsletter where, if you're the old-fashioned person who reads emails, You can also sign up and get an email about what is going on in the Twitter nephrology world. And these are the times. We have 3 chats. For the European crowd, it's on 9 p.m. GMT or British Standard Time, as it may be, and an hour later for the Central European time. There's also an Asian chat as well as the American chat. So there are 3 different time zones. And the story so far is that we have had more than 150 sessions. This is the first 135 sessions, and roughly about 100 people or more joined these chats, and the growth has been steady. So as of the last year, it's the number has gone up to about 200 people who are actively tweeting and joining in these journal clubs with over 1,000 tweets during that hour. Now, with respect to moving on to COVID-19, so our interest was peaked when in early March, the news came in that perhaps hypertension is a risk factor for COVID-19. It's either a risk factor, it was being described for people getting COVID-19, or perhaps a risk factor for more severe disease. And the BMJ and Lancet, reputable journals, published articles or correspondence saying that maybe being on an ACE inhibitor or an ARB might be harmful. Now, of course, we know that that is not really true. But at that point, what I got together with Matt and said, hey, let's look at the data. We were still waiting. We didn't have many cases. We said, at least let's get the community together and put the information out there. So we started this page, which was just looking at hypertension and ACE2. But then it sort of started proliferating. So now we have some data on transplant and COVID-19, on dialysis and COVID-19, even some pediatric data, as well as, of course, acute kidney injury that we'll hear more from Kevin later today. So the kind of things we are trying to cover is, for example, on the AKI page, we have frequently asked questions such as, what is the risk of AKI in COVID-19? What are the causes and characteristics of AKI? Is the virus present in the urine, the blood, the effluent? Should we start dialysis early? Does modality matter? What about these, adsorption filters? Does the dose of dialysis matter? Most importantly, the questions right now are about contingencies. Do we have enough CRRT machines? Is there, how can we do SLED? What about anticoagulation? Some places such as New York especially have started even doing acute peritoneal dialysis. So what are the challenges with doing that? And we are just, we are not the experts necessarily. As you've seen, I have not treated many patients myself, but we have mobilized the community to provide the answers. And we are trying to put them as time goes on and update these pages. For example, just to show some of the difficulties of looking at the data, this is a table which shows the incidence of AKI. Now, these first 3 studies, which are from Lancet or Lancet Respiratory Medicine, they are all from the same institution. I do suspect there's a lot of double counting going on, and they are not always clearly identified as to what is the, whether these papers are getting published again or the numbers increase. So is it like an updated version of the paper, especially when you have got preprints as well as papers that are being published subsequently. For example, this paper in Kidney International from Cheng, I'm pretty sure there's another paper which was published as a preprint from the same institution with very similar numbers. There's also another paper in the BMJ published by the same authors, which has very similar numbers and 133 deaths, which is exactly the same. Again, there's nothing wrong in necessarily doing it. But when you're critically appraising the literature, I think it's very important that you are able to identify that. And that's sort of what our purpose is, to say, hey, look at these things carefully. There's another paper published in the American Journal of Nephrology, which says there is no AKI. And Kevin and others can say that, this is absolutely false. There's a huge amount of AKI that we see in COVID-19. And there are problems with some of these papers that are coming out that we discuss. More importantly, the risk of acute kidney injury in critically ill patients is probably more around 20% and not the early reports which said, 0 to 5%. We talk about, drug dosing, not to say that any of these drugs have utility. If there are clinical trials, please enroll patients in clinical trials. But if these drugs are being used, it's important to, adjust the doses in your patients. Again, with hypertension, similarly, there was this report that hypertension is very high in patients with COVID. But Matt Luther suggested, let's look at the enhanced data. And you can see here clearly that the prevalence of hypertension goes up with age. So what you are seeing is that older people are getting COVID, older people have bad outcomes, and hypertension is probably just a confounder. It's just there for the ride. It's not necessarily to blame. And if you see these last two papers in the table, again, they are preprints. They have adjusted for age, and once you adjust for age, it doesn't look like hypertension itself is very important. With respect to the ACE2 story, some of the earlier reports, in fact, so there's ACE2, there's AT2, there's ANG2, there's ANG Roman numeral 2, and there's ANG2. All of these things mean different things. And unless you're a nephrologist or someone who's really working in this field, the initial papers and reports were very confusing, and they were mixing up these numbers, these terms. And on outcomes, as you can see, the last column here in this table shows how the poor quality of the studies, which are talking about ACE, ARBs, and outcomes. The headlines are very interesting, saying, oh, ACE inhibitors may be protective and ARBs might be protective, but really, there's a lot of caveats that you should be looking at. The last paper there by Bean from UK seems to be the strongest data so far, but again, it's based on small numbers, 105 patients, of whom 37 were on ACE inhibitors. So it's really hard to draw any conclusions. And that's the lesson right now for many of these stories. But most importantly, I am the face talking today, but it takes a village to put all these things together. So for all, I've just put the names of the contributors. We have the lucky part about NephJC and Twitter is that there's a huge community of nephrologists and scientists and hypertensionologists and others who are involved, and intensivists. And they're all contributing. They're all saying, hey, hey, Swapnil, no, this is not right. Fix this. This is what you should be doing. So we have a continuous peer review going on and continuous updates going on to these pages, which I think is a strength. I'm sure we cannot get everything perfect on day one, but having a blog which is updated in real time makes it easier. And again, these are live updates, and this is just if you scroll down to any of these pages, we are trying to keep track of what is going on and what have we changed as time goes on. And this is the era of FOMED, right? So free open access medical education, just like the ERA-EDTA is doing with these webinars. We are learning, and COVID has made us, it has made this whole thing extremely important for us to share whatever we are learning with each other in real time. So that's again the page for all the COVID resources that are there on NephJC, the nephjc.com/COVID-19. We would love to have more people join us and give us help and resources. So feel free to tweet at me or email me if you want to help us. Thank you.
Thanks, Swap. That was great. So NephJC is, I think is a very important resource, particularly in the current situation where I think born out of an eagerness to find some kind of treatment or therapy that's going to work for patients. There's been lots of things that have been produced very quickly, and I think it's important to identify that the data is not always perfect, and the messages we draw from it have to be as a result of critical appraisal. Ali, I don't know, you normally have a strong opinion. I don't know whether or not you'd like to pass comment on some of the studies and things that have been published in terms of treatments and therapies. Ali?
Hi there. Yes. Hi, Kate. And maybe, so I think, are you asking me to directly comment on the Swapnil, so to take it further and talk about the GlomCon experience?
So I think we'll move to your presentation in a second, but I think that what Swap is saying is that there's lots of papers and they're doing a terrific job putting them all together. But one of the issues is that we can't always take as read what's in these papers.
Yeah. Yes, and I think and I think so. To emphasize what Swapnil said, we are getting hit with a tsunami of literature coming at us from the various centers experiencing the surge in COVID. And I think these studies on the one hand are great because right now we have, everyone is talking about we need data. So we are really hungry for data in any systematically measured and assessed way we can get. So there is a lot of stuff on the preprint servers to have it come out and be public fast. There is a lot of studies being published in peer-reviewed reputable journals, which in the second line of thought we may look at it critically. And I think that's the important aspect of for example, the work as Swapnil and the NephJC team is doing, is to curate all that information and make it a little bit more digestible. I think we see reports of AKI from 0 to 40%, right, in critically ill COVID patient. Some studies may be recycled and publish the same kind of data in 3 different manners, kind of skewing our perspective in how things are, where actually there is a widespread. So it's that balance of us being all in the complete dark and having nothing to know to how to prepare, and getting the data a little bit maybe too fast or too unscrutinized, assessed and looked at. So I think that's why your webinar here or the NephJC working thing is all important to help us filter through the information.
Yeah, so I think experience is very valuable here. So Kevin, I won't ask you to comment just now because I'm hoping that you might touch on some of these things when you're talking later on. So can we move on to our next presentation? So it's from Prof. Ali Poimer, who you've just heard speaking, one of the founding directors of GlomCon. So he's going to share with us some information from the most recent GlomCon session regarding immunosuppression management in both GN and transplant patients. So that's something that our community has had lots of questions and queries about. Ali.
And thank you for having me here today, Kate, and the ERA-EDTA team. So I will be presenting here kind of an excerpt from GlomCon session we had 3 weeks ago about management of patient on immunosuppressant. It was at that time, the session was on glomerulonephritis, patient with glomerulonephritis and transplant patient. Disclosures, no financial conflicts of interest. And really that, just to emphasize it here, is that all things expressed are opinion-based. It's not that we have any scientific data to guide us, but even the experiences are very limited. So it's like even more watered down expert-based opinion. We were very fortunate to have Dr. Brad Rovin, Debbie Gibson, Deborah Addy, and Nelson Ghosh at that time take us through. And I'm just going to go briefly what the discussion points were, and also what we are here locally kind of practicing. And that all basically can be distilled to 3 key principles: looking at the GN patient or transplant patient with we consider immune compromised, either due to their disease state or due to their medication they are on. And it's like looking at minimizing their healthcare exposure, anything we can do to minimize that, minimize the immunosuppressive regimen to the extent allowable. And that's really important. To the extent allowable is like you don't want to risk a relapse in these patients or let them go untreated. And the other thing is, and that's a little bit more unclear, but something to consider, is the first line agents we use for on this patient, our go-to medication, and whether we should think of it a little bit differently and consider some alternatives. And of course, that does not all obviate the fundamental need for social distancing, isolation, good hygiene, washing hands, not touching face, using face mask, and other things we do usually in our patients, but now even more so, to be rigorous about prophylactic vaccination, right? So the patient still can get the flu and pneumococcal infection and those things. So making sure that the patient is up to date on all the other things, housekeeping items in these patients. So a little bit more rigor to go through the patient list. So when we talk about minimizing healthcare exposure, the things to consider are decreasing, for example, the frequency of blood draws. We sometimes have in our standard approaches of how often we follow the patient with chronic stable lupus nephritis who is in remission, or the patient with ANCA vasculitis, or minimal change disease, membranous, all those patients, and we may need to reconsider of whether can we decrease and increase decrease the frequency, increase the spacing, or consolidate, be more cognizant about that when the patient goes from for other healthcare visits to make sure that it's more coordinated. Uh, these are small steps, but again, important. Decreasing the rate of healthcare exposure by 50% decreases the chance of coming into a cohort with high prevalence of disease potentially. We here locally look at where are the kind of peaks and tides of patient visits to the local phlebotomy, local lab. For example, at the end of the week, early in the morning, there's less visits, so we try to guide patient with this regard. And the other thing is like patient who is usually like whom you check the urine protein creatinine or urine heme for signs of relapse, the patient you have maintained on minimal change in remission, or the patient you have maintained well on your lupus regimen. Maybe they can, some of the patient, not all of them, but some of the patient can self-monitor, right? Rather coming in for the urine analyses and urine studies, maybe they can check a urine home dipstick and have it this way a little bit more self-managed and less exposed to the healthcare setting. Mail order pharmacy, locally here we manage with the patient, the majority of the patient get now their medications mailed so that they don't need to come to the pharmacy. And then the question of the biopsies, and that's again, just emphasizing that it needs to be adapted to the local practice and with the patient you practice. But the question is, should we now be a little bit more comfortable in managing the patient with serum PLA2R titer without the biopsy? Or a patient with active nephritic presentation and rising ANCA titers who had been stably maintained, does that warrant a biopsy or not? And I'm sure people could get in a very heated discussion about these things, but at least thinking about these aspects to the extent I think it pushes us to think through that. The question of immunosuppressive regimen, I think, again, the last thing we would want in the setting of this crisis is for any patient to flare, right? So a patient who is stably maintained on a good regimen for the lupus nephritis is way better off than someone who is now panicky trying to hold off their immunosuppressive regimen and goes into relapse. Same thing could be thought about transplant. We're really actively reaching out to transplant patients to make sure that they don't stop their immunosuppressive regimen out of the fear, because again, a rejection and flare is all worse. It has them come in to the hospital. They need to be treated with a higher dose regimen of immunosuppressant and things. But if there is a time to go through the patient list you have and think, are your patients up to the kind of milestones with you titrating the steroid down? Is it a good time? And re-looking at your census and the patient list and the patient who hit the 2-year mark after the maintenance regimen, is it a good time now to wean it? Sometimes I think some patient may fall through the cracks and they continue their higher dose steroid inadvertently and thing. And I think now it's the time to go through those lists and see who can be really maintained on the maximum needed amount of suppression and not anymore. And the other thing is also, again, something to be discussed and debated based on the different opinions, is like your IgA nephropathy patient, whom many would actually not treat with steroids, but some readily treat with steroids. Is there now time to think, okay, the patient who is otherwise has a stable renal function, some moderate proteinuria, can you hold off the next 3 to 6 months with going on your trial of the steroid therapy or not? And I think this is something to be discussed with the patient. There are individual risk factors and things, but these are the things one can think through. And with regard of minimizing risk to the patient who are immune suppressed. With this, maybe I also just want to editorialize. With all the data we have, and Swapnil and colleagues have curated a lot of it, particularly with regard of kidney function, and I think a lot of the data is coming out on patient with transplant and to be published within the next weeks and months, is to what extent are patients who are immunosuppressed actually more prone to adverse outcomes or not. We know that they likely more readily will contract the infection, but how their outcome is going to be different in the general population or the CKD population is yet to be known. So we are a little bit in the dark in that. And then the last thing to add is like first line agents. So that your patient now is being diagnosed with minimal change disease or with membranous. What first line regimen would you use? I think now people have been at the baseline some people very concerned about the use of certain immunosuppressive medication compared to others. Let's take, for example, membranous nephropathy, where we have the group of folks who use as their first line choice calcineurin inhibitors, and those who, as the first line, defer to cyclophosphamide. And now with the Mentor trial out, many use rituximab, right? So which one puts the patient at more risk? And we don't know it. All right, so people are kind of opining or trying to discuss those with their patient individually. The general thought is that cyclophosphamide infusion or rituximab infusion is a long-lasting immunosuppressive effect. So when you give your patient, for example, rituximab, you diminish their ability to mount IgGs in the setting of an acute infection. Your patient with who is on calcineurin inhibitor, in the setting of an acute infection, at any time you can stop and reverse kind of the immunosuppressive effect. You can down titrate it. In the setting of rituximab, it's kind of you can't go back anymore. So these are the consideration one may take into factoring of what immunosuppressive regimen would be chosen or should be chosen. And we don't have the data to guide us, but I think now people may tend to err on those regimens which are readily daily titratable, weanable, stoppable, and considered, not known, but considered to be less, I would say, less risky in the setting of an active infection or predisposing to an active infection. And I think so with this I end and I'll open it to any questions or comments, maybe based on Kate or later.
Thank you, Ali, that was great. So I guess just on the basis of your last slide, so I think what you're saying is true about cyclophosphamide and rituximab, and we try not to use them. What about a CNI and having to bring people up and down to the hospital frequently to check the levels? Do you think that's as risky, less risky?
We don't know, but a great point. So when we, for example, the question of minimal change, right? So you have either the choice of high dose steroids, CNI, MMF could be used, and rituximab could be used, and cyclophosphamide in the relapsing setting. So if you do the CNI and you want to be effective, you need your patient to come in for the blood draw, and is that probably? I think I don't know. I don't know the answer to that.
Yeah, okay, so there's a couple of questions from the participants, and I suspect the answer to them will be, we don't know the answer either, but I'm going to tell you what they are. So, do you recommend biopsying nephrotic range proteinuria in a patient who is COVID-19 positive but is well and at home? So you've checked a PLA2 receptor antibody and it's negative. So I guess the feeling is that this patient's got membranous, but they haven't had a biopsy. So what would you do?
So that it's nephrotic range proteinuria definitely needs attention and treatment. So this, for example, a patient with sudden acute nephrotic range proteinuria or RPGN, these are not the patient we would recommend to not biopsy or not look at that, because even that underlying disease predisposes to infection. We know nephrotic syndrome is a high risk for infection. If the patient is COVID positive, I would, my personal perspective would be to actually at that moment maybe let the patient recuperate and really make sure that they are clinically stable before proceeding to biopsy. Not necessarily because of avoiding to bring them in and have others exposed. The patient already got the infection, but because of if the patient would clinically deteriorate, you don't want to have it probably in the setting of an acute infection. And I'm also not sure, I'm not sure that in the setting of an acute COVID infection, I would initiate immunosuppressive therapy, even if that is nephrotic syndrome at that moment. So I think it would depend a little bit. If the PLA2R is negative, nephrotic syndrome could be minimal change, could be FSGS, could still be membranous, secondary membranous, or even primary PLA2R negative membranous, and probably warrant some form of immunosuppressive therapy.
Would you be happy to start an ACE? Swap.
Swapnil, should we start an ACE? So here's the thing. So look, the ACE or ARB for patient with nephrotic syndrome is not acutely kidney saving and is not acutely life saving. So it's something, I think a patient who is nephrotic syndrome, unless the serum albumin is 1.5 or less than 2, I would be inclined to, if the serum albumin is anything above 2.5, I would be inclined to sit through it for the next 2 to 4 weeks until the COVID infection is over. Now, I don't believe in coincidences. So the patient contracts COVID-19 and develops nephrotic syndrome, I would think of it possibly related, right? There are many there are numerous viral infections which cause nephrotic syndrome, whether it's due to minimal change, FSGS, membranous, all those things. So I would spend more time in writing it up as a case report than trying to be a cowboy, I think.
Okay, let's have swap. Would you start an ACE inhibitor acutely? No, we lost him.
So I think the effect is small, right? If someone's very florid, not sure how much an ACE inhibitor is going to make a difference. To be honest, it may reduce the proteinuria a little bit. Having said that, I would encourage everyone to enroll patients into trials. So there is an Irish trial looking at ACE inhibitors and ARBs, a very large Irish trial. There's another one by Jordi Cohen from UPenn looking at similar situations. So of course, that's ACE inhibitors in COVID, but that's what I would encourage. There's also a few case reports. What do you think, Ali, about that with collapsing glomerular nephropathy in the setting of COVID? And do you want to comment on that?
Yes, so and there was that case report, which was that I think that African American patient. There were also some verbal communications with colleagues who had seen it in their patient, and we see a patient of African ancestry with high risk of FSGS, and that being associated with APOL1 risk alleles. And I think that, and we now have kind of mounting evidence or data that a kind of high interferon state, infection, inflammation, can be a driver of is a potential driver of APOL1 associated FSGS. So it's unsurprising to see an acute viral infection, which is kind of reported to be a major driver of a cytokine storm, or however you call that, to see collapsing FSGS. So yes.
Okay, so we've a couple of other questions, but I'm going to leave them to the end if that's okay, because I'd like to move on to our next speaker. So thank you, Ali, and thank you, SWAP. So I'm really pleased that Prof. Kevin Rooney, who's a consultant in anaesthetics and intensive care medicine in Paisley, just outside Glasgow, has agreed to share his experience with us today. We've had lots and lots of questions about intensive care and how they're managing, generally, and how they're managing patients on RRT. So Kevin, we're really interested to hear what you have to say. Oh, Kevin, you're on mute still.
Okay, thank you, Kate, for inviting us to speak today. For those of you who don't know, I first met Kate, I think it must have been about 15 or 16 years ago, as she was a brand new doctor and I was a relatively young consultant. So it's great to see her blossom over the course of time. So as Kate said, I'm a consultant in intensive care in NHS Greater Glasgow and Clyde. And that is my hospital there in the middle, the Royal Alexandra Hospital, which is really one of 4 now acute hospitals within NHS Greater Glasgow and Clyde. And that counts for the small blue area in Scotland, with a core population of about 1.2 million people, and we provide tertiary referral services for about 50% of Scotland, so about 2.5 million people. I'm a fellow for the Scottish Patient Safety Campaign, and I led 2 campaigns, one to improve outcomes from cardiac arrest and one to improve outcomes from sepsis, both of which reduced the rate by 28%. So part of my academic interest is about improving the quality of care that we deliver. And I'm faculty of the Institute for Healthcare Improvement. And I have no conflicts of interest. And again, this is, in my opinion, not necessarily always evidence informed. So I was a bit overawed by that last presentation, which was certainly above my head and made me realise that I was never clever enough to be a renal physician. So Kate asked me what have I learned over the course of COVID-19. And I suppose that the first thing that I've learned, and probably the most important thing I've learned, is the importance of flattening the curve. Because actually what that did, that was basically has allowed us to stretch out the number of cases that we see, so that we can kind of keep it within the capacity of the healthcare system that we see. So thanks to things like lockdown and social distancing. So that is essentially allowed us to cope better with healthcare capacity than we would have otherwise. We have seen I work in a 700-bedded hospital, and we have 7 level 3 ICU beds. We went quickly from 7 to 9. We opened up the 2 empty beds in the ICU unit. Then we opened up a second ICU and up to 17 beds. And we're now looking about opening up a 3rd area in the hospital where we can ventilate patients in theatre recovery, and that will take us up to 24 beds. What is really interesting to me is that the rest of the hospital is quiet. We are currently about 250% capacity of normal, but acute medicine, which used to admit about 70 patients a day, is maybe only admitted 15 to 20. This is seen across all medical and surgical specialties, and it's interesting to find out where has all the disease gone. So when I think about splitting it up and what I've learned, I think it's important to think about it from an operational perspective and from a clinical perspective. So we'll first of all think about it from an operational perspective. Well, I think the most important thing you need to do is prepare, prepare, prepare. We've known this has been coming and we prepared, but I don't think we prepared thinking it would be that bad. What is your hospital surge capacity? Can you double your intensive care beds? Can you quadruple them? That's what we've had to do. There was even talk at one time of actually increasing our critical care capacity by 8-fold, because as I said, the rest of the hospital is quite quiet and there's wards empty. But when we talk about increasing critical care capacity, people think it's just about, oh, we need more ventilators. Where are we going to get the ventilators from? Are we going to use theatre ventilators? Are we going to buy new ones? Can people produce them quickly enough? But it's actually far more important that it's more than just ventilators. There's other equipment which keeps intensive care units running on a daily basis. There's the invasive monitoring cables, syringe drivers, renal replacement therapy machines, feeding pumps, blood gas analyzers, trolleys, ultrasound devices, beds, a resuscitation trolley for the new area, a difficult airway kit. And there's also the things about, have you got enough PPE and consumables to cope with the surges that you're going to see? One patient can go through about 50 sets of masks for the number of people that see them on a daily basis. You need to also think about, have you got enough power in your area to be able to run further ICUs? What's the maximum number of devices that actually a clinical area can hold? Again, what's really important is actually oxygen. So people think we can just open up another intensive care unit, but you need to be able to figure out the number of oxygen outlets that your hospital can simultaneously run and where they are, and it is supported by your oxygen tanks outside the hospital and the location. The further your clinical area is away from the oxygen tanks, the less likely the flow will be able to keep up. You need to find out what are the flow rates of your ventilators, what are the flow rates of non-invasive ventilation, high flow nasal oxygen. That was really routine practice beforehand, but we've had to abandon it due to the 60 litres per minute that it actually uses. Think about, are you going to need a portable oxygen concentrator? What's your capacity for this? Can you put them in the wards, and are they ready for use? You need to communicate with your colleagues actually about reducing the consumption of oxygen. We want to avoid hyperoxia so people don't need SATs of 99%, and we want to eliminate waste. And you need to make sure that you have cylinders throughout the hospital to facilitate transfer and also for emergency use. You need to also think about things like the air supply within your hospital, the number of outlets and where they are, because what you can do is you convert your hospital ventilators to run on air rather than just purely oxygen, and that will save some of your oxygen supply. It's important that the importance of team communication and working is key to this. No one person can be responsible for everything, so you need to have shared leadership, regular meetings on a daily basis, and you need to have a situational awareness about what's going on within your hospital, within the ICU, how many COVID patients there are in the hospital, and what is the capacity in your neighbouring hospitals. You'll need to perform hospital walk rounds and go around the hospital saying, where could we next move the intensive care unit to be? What is our escalation plan? The importance actually of, rather than having staff face-to-face meetings that we normally do in the hospital, our weekly multidisciplinary team meeting is now a virtual meeting and using things like Teams, Skype, or Zoom. We need to actually be aware about the mental health and the well-being of our staff. The staff currently are under a lot of pressure, a lot of stress. The critical care staff, we have trained for this our whole lives, but we've now got nursing staff from operating theatres, from recoveries, from general wards, all now helping out in intensive care. But then also with our staff, we need to support the staff in the high-risk groups. So what members of staff do we have that are immunosuppressed, other comorbidities, or those near retirement? We need to actually, too many spelling errors I've just seen, tired last night obviously, but we need to make sure that we protect our staff, because certainly the NHS's greatest asset is our staff. If we don't manage our staff well, we won't have an NHS in the future. Other thing to think about is imaging. where can you leave the portable chest X-ray machine rather than always having to clean it and decontaminate it? With regards to increased use of point of care ultrasound to make diagnosis rather than taking the patient to CT. When you have the CTs, have a CT that's used for COVID patients and one for non-COVID patients, because that will increase the flow. I think with the elective capacity, this is something we could have probably have done better. We should have reduced it sooner. We need to early reduce the elective capacity of operating suites in those requiring prolonged admission to hospital. So if it's a day case, that's fine to continue doing it, but certainly nearer the end, you need to cancel the hips, the laparotomies, and all these things. If you cancel your elective operating, it facilitates redeployment of staff and it facilitates the training. And certainly we are only now limiting our operations to urgent and cancer cases. You need to think about what investigations you're going to do and what about medical records during the pandemic and in your cohorted areas. So you'll need to develop electronic solutions and work closely with your IT. Develop lab order sets for COVID admission and also daily order sets for COVID patients so that we eliminate non-essential investigations. And also need to look at things like point of care testing. So as we've opened up our other ICUs, we've had to look at about getting more blood gas analyzers. Pharmacy is key to running a hospital and it's even more key to running an intensive care unit. So yes, we can quadruple our ICUs, but we need to plan the medication requirements based on our maximum surge capacity. So we need to think about our sedatives, our opioids, our vasopressors and muscle relaxants, our NG feeding, our VTE prophylaxis, stress sulfur prophylaxis, electrolytes, RRT and diuretics. All of these drugs are needed on a daily basis within the intensive care unit. And we need to look at new ways of delivering our drugs rather than using an infusion, to giving boluses or instead actually using the NG route. Unfortunately, we've had to restrict visiting and access to patients. And actually patients now only get to visit, relatives only get to visit their patients when they're near the end of life. So we've had to look at new ways for patients to see their relatives and use of mobile devices and Skype and FaceTime. Other things for operational planning is the importance of our staff and staffing. We need to train and practice, because we're taking people from outside critical care and using them to staff and man the ICUs. You want to identify those that are available and those with the expertise. So those in anaesthesia, surgical and medical specialties. Look at your ex-critical care staff within the hospital and also take rotating trainee doctors who've recently worked in ICU and bring them back. We need to redeploy staff based on their skills rather than necessarily than their seniority. Someone may be more junior, but actually they've got greater skills in that clinical area. And we're now seeing that rather than having one-to-one nursing care in the ICU, we've got one ICU nurse looking after maybe 2-3 patients, and the staff are now becoming more supervisory rather than having a bedside clinical care. Anybody can help with moving equipment, restocking, administrative tasks and positioning. My brother is an orthopaedic surgeon, and they've been roped into helping with prone positioning of people and staff. We've moved to having being resident on call now. I used to do on call from home, and now we're doing 13-hour shifts, so we can provide at least 2 to 3 ICU consultants in the hospital on a daily basis. And actually, we're playing to people's skills. Any anaesthetist can intubate, can stick lines in, and can emergency resuscitate a patient. But not everyone can have the day-to-day planning in intensive care. So we're late about doing this, but certainly I think it's important to set up a MERIT or more mobile emergency rapid sequence induction teams. So teams to go around the hospital, pick up a critical ill patient, intubate them, and then bring them to the ICU. So what are the clinical issues that we see day to day? Well, as I said, we need to think about conserving oxygen supply. So actually, the days of giving everyone SATs of 96 to 98% are long gone. And we need to actually target our oxygen saturations now down to 92 to 96%. In ICU, we are actually targeting from 90 to 94 or 90 to 92. We need to avoid the hyperoxia, and we need to avoid using devices like high flow nasal oxygen. So there's a growing evidence that actually we should be trying and avoiding invasive intubation in these patients, and by using things like CPAP therapy or non-invasive therapy is shown to be beneficial, and is actually being used in some patients who maybe have treatment escalation plans in place as well. We can use oxygen therapy, we can use CPAP, and we can use actually patient positioning in the prone position, even in unventilated patients, to improve their oxygenation. We need to think about where we can intubate these, look after these patients. And we all know that within every hospital that our negative pressure rooms are limited. So the result, we've actually had cohort patients in areas where we're doing aerosol generating procedures. And now when you get into our ICU, you have to wear full PPE from the minute you walk into the clinical area. And what we are doing is we're saving our single rooms for those requiring non-invasive ventilation, or indeed those critically ill patients who don't have COVID-19. Intubation is an aerosol generating procedure, and we've had to completely change the way we intubate a critically ill patient. We now use Mapleston C circuits instead of ambient bags. We use low flow, low pressure circuits to help with bag valve mask ventilation. We try and avoid the bag valve mask ventilation, and we intubate the patient as quickly as possible. That's quite sporting because they're profoundly hypoxic already, and we make sure it's the most senior doctor that available that intubates the patient, rather than having the doctors in training do it. How do we ventilate COVID-19 patients? Well, we're just using our established ventilatory management techniques. So we use kind of ARDS management, so protective lung ventilation, a conservative fluid strategy, muscle relaxation, neuromuscular block. And I've actually moved away from the high PEEP using ARDS net strategies to using a lower PEEP. These patients initially have very, very compliant lungs. And again, we're using more and more prone ventilation. So what is prone ventilation? Well, prone ventilation is essentially taking a ventilated patient and turning them from the supine position and lying them face down prone and with some head of the bed elevation at 40 degrees. Why do we do that? Well, we know that basically in the supine position, what happens is your transpulmonary pressure due to atelectasis and collapse in your posterior part of your lungs, your alveolus is collapsed. And as a result of the transpulmonary pressure, you preferentially ventilate your ventral alveoli, and we actually end up over-distending these alveoli and further damaging them. And actually what happens is we are perfusing the most dependent part of the lungs, so we're getting a big shunt. What we do is by moving the patient to the supine, the prone position, we are kind of evening out the transpulmonary pressure. We're taking off the pressure from the heart lying in the lungs, and the heart now lies on the sternum. We're getting less over-distension, and we're getting a more uniform ventilation across the body. And actually we're still seeing that there's preferential perfusion to the posterior parts of the lung and better and reduced shunt. This all improves your oxygenation, and also when the patients are prone, we also see increased secretion clearance. What makes life difficult was actually because ICUs are full of aerosol generating procedures, nursing and caring for patients for hours at a time in full PPE becomes very, very difficult. The supply of the PPE is difficult as well, to ensuring that we have enough, because we didn't know how much equipment we would actually get through. Other things that are worth commenting on is the use of corticosteroids in these patients. Within critical care, we've had what I would call a love affair with steroids. we love giving them. Then we had a study that shows they work. Then we give you another study which shows they don't work. And so much so that over the years we've seen intensivists usually the 2 to 3 week down the line say, I don't know what to do, let's start steroids. And then you say, look, the patient got better. But I'd put that down to the SASH effect, because intensive care is supportive care. And if we wait long enough and support the care, patients usually get better on their own. We know that high-dose steroids is bad for you. You see worse outcome in many critical care patients, and you see a worse outcome in H1N1 and other coronaviruses. And you see prolonged viral shedding. However, there is an evidence case that low-dose steroids may actually be beneficial. And I'll talk about one of our studies later on that we're delivering low-dose steroids as part of a randomized controlled trial. Or we also give them when clinically indicated. So someone's asthmatic, we would normally give steroids, we would continue to give steroids. If they've got vaso-dependent septic shock, again, we would give low-dose steroids. Cardiac arrests are proved to be challenging. Thankfully, they are rare, but they are a high-risk aerosol-generating procedure. And as such, we've moved to compression-only CPR initially until everyone is in full PPE. Because chest compression is not an aerosol generating procedure, whereas bag valve mask ventilation is an aerosol generating procedure. There's a huge variability of critical care bed numbers in Europe and across the world. So if we take the United Kingdom, this is data from 2006, we have 6.6 critical care beds per 100,000 capita of the population. If you take Germany, they've got 5 times more critical care beds per head of the population than we do. We spend an average £3,000 per person on healthcare. I think in Germany it's about £4,500 per person. I think United States, maybe North America, then their critical care beds per head of the population, 100,000, is about 50. So we've got a very lower provision of critical care than other European countries. And as a result, we've had to look at ways and how do we deliver critical care to our population. We deliver critical care in a fair way, I believe. When patients come into hospital, we perform the clinical frailty scale. If that is above 5, we then can have a shared decision making with the patients and their families. It's important we consider comorbidities and the patient's underlying health conditions. Is their condition, is it going to be reversible? And then we discuss with the patient, if able, and their families, the risks, benefits, and the likely outcomes of different treatment options. Within the UK, there's currently no critical care triage on admission or during our ICU stay, and patients with end-stage renal disease are still seeing access to critical care. So what about the demographics of the patient that we're seeing? Well, the median time from onset of symptoms to hospital admissions is about 4 days. And the median time from onset of symptoms to ICU admission is usually about 7 days. And they usually present in their second week of illness. The critically ill are mainly the 50 to 75-year-olds, and we are seeing several 40-year-olds. And the most common symptoms that we see are cough, fever, and shortness of breath. The most common comorbidities are chronic cardiac disease, diabetes, and chronic pulmonary disease. And actually, obesity is a key risk factor as well. It seems to be more common in men than compared to women. It's 70% versus 30%. And I think this isn't a genetic predisposition. I think it's we men make poor lifestyle choices. We tend to overeat, overdrink, oversmoke. So I think that's the reason. Over 70% of patients have a BMI of greater than 25. And this certainly seems to be mostly within the critical care patients we're seeing a disease predominantly affecting the elderly and those with increased BMIs. 2% of patients have end-stage renal disease on presentation, and they are 1.58 times more likely to die than other people. But again, if you're obese, you have a similar odds ratio of death as well. Here is some data from ICNARC, that's the Intensive Care National Audit Group, and covering UK and England. The Scottish data isn't ready, but they've looked at the first 3,883 patients in England that have been admitted to ICU. And if they compared COVID-19, which is a middle column, compared to patients with viral pneumonia between 2017 and 2019, as you can see, there is about a 50% mortality in patients with COVID-19. 67% of the patients receive advanced respiratory support, so by that we mean invasive ventilation. 25% are receiving advanced cardiovascular support, and by that we mean 2 or more vasopressors. 90% are receiving invasive monitoring and 1 vasopressor. With regards to renal support, in England, there's currently it's about 20% of people requiring renal support. Currently in Scotland, about 40% are requiring renal support. And the average time on a ventilator is about 7 days, and the average time for patients requiring renal support is about 4 days. This is an interesting graph here, because if you look at the black line, you can see that the mortality in ICU for all patients is about 50%. However, if those that don't require mechanical ventilation, 70% of them survive. But when you do require mechanical ventilation, only 35% of them survive. We're also seeing that there is an increased mortality in the elderly, and if you're over 70 and you require intensive care, you have a greater than 70% chance of dying. So what are the issues that we're seeing with regards to renal patients? Well, certainly that our central dialysis and arterial lines are all more likely to clot. Our central lines and arterial lines are getting clotted limbs all the time. When patients are on the RRT circuits, they are more likely to clot as well. And we've had to, because we've got fewer machines, we've had to look at moving to timed treatments. And we use citrate and things like pre-dilution, increasing the blood pump speed, and some people are moving back to using heparin and systemic anticoagulation as well. I think the causes of an acute kidney injury in these patients is multifactorial, but we're not seeing the normal community-acquired pneumonia who comes in septic shock and hypotensive. The patients don't present like that. They present and they look incongruously well. They're profoundly hypoxic, but they aren't really tachycardic. They aren't hypotensive, but they are tachypneic. When we induce anesthesia and we intubate them, they tend to not drop their blood pressure, but they are very dehydrated because of the high insensible losses from having a temperature of 39 for a week. So I think the causes are hypoxia, because of the AKI, or hypoxia, hypotension, hypovolemia, and I certainly think if you've got an already chronic kidney disease, you're more likely to get renal failure. And again, I think there's some hypercoagulable state that may account for this as well. And there is a greater incidence of VTE in these patients. And I'm putting this down to these patients are already dehydrated with high insensible losses. They may have been aggressively diuresed by trying to offload them. And as a result, we are running these patients as dry as we would normally run someone with ARDS. And we're now individually titrating the fluid balance as per patient, because we're seeing a lot of patients with high sodiums and high ureas due to dehydration. I think we're going to move from the routine 40 milligrams of enoxaparin for VTE prophylaxis. We're moving the goalposts that will take it right down to platelets of 25 now with the VTE prophylaxis, and we may even be looking at moving to 40 milligrams of enoxaparin twice a day, or maybe even titrating against an anti-10A level. We're also seeing a huge amount of insulin resistance in these patients, and along with the obesity goes type 2 diabetes. And whereas these patients may not be on insulin in the community, when they become critically ill, they may be requiring 20 to 30 units of insulin per hour. We're currently taking part in a couple of studies. Kate asked me to talk a bit about any studies we're taking part in. One of them is a recovery study, which is a UK study led by the University of Oxford. And it's open to ICU and non-ICU patients, and it's anyone over the age of 18 who's admitted to hospital with initially proven but now suspected SARS-CoV-2 infection. There are 5 arms. There's a standard care arm, there's a Kaletra, lopinavir, and ritonavir, there's low-dose steroid, dexamethasone, and there's hydroxychloroquine and azithromycin. Within the UK, we feel quite strongly that throughout the world, people are using a lot of these treatments, but we actually don't know if it works, and we're keen in developing an evidence-informed practice. There's also a peculiarly critical care study, REMAP-CAP, which is a randomised, embedded, multifactorial adaptive design study, where each patient is randomised to receiving multiple treatments. There's an antiviral arm, there's a corticosteroid arm, and there's an immunomodulation arm. The antivirals is a control, no treatment, Kaletra, hydroxychloroquine, or a combination of Kaletra and hydroxychloroquine. The steroids is control, a fixed dose of low-dose steroids of 50 hydrocortisone 7 days, or only while in septic shock. And last but not least, there's going to be immunomodulation with interferon beta or anakinra. So that's been a whirlwind of my experience with COVID-19 patients. I think we've looked after about 40 patients. I think we've discharged about 10 to 12, and we've had 3 deaths in my hospital so far. And I'm hopefully I've answered most of Kate's questions, but if not, I'm happy to answer the ones I've forgotten.
So Kevin, thank you. That was great. That was a really comprehensive summary of what's happening. And I think if anything like this happens again, you definitely be the person to be involved in the planning. So you seem to have learned an awful lot and made some very valid points about how you plan for something like this and how you manage it. We've had a question from the audience asking about steroids. So if you are not, or if a patient's not being recruited into a trial, are you giving them low-dose steroid, and what protocol are you using?
So we wouldn't give them because there isn't the evidence to say actually, there's no randomized controlled trial to say that it is beneficial. We would give someone steroids for the route. So if they were normally would get steroids, so if you got an infective exacerbation of COPD, if you got asthmatic and they would normally get steroids, we will give it then. If someone is in septic shock, that is resistant to vasopressors, so that would be I'd say that'd be about 8 milligrams and 50 of noradrenaline, maybe double figures, but a bit above 10 mils an hour. We would give them hydrocortisone 50 milligrams 4 times a day. But we aren't giving people steroids to manage COVID-19 unless it's as part of the study, because we strongly believe we want our practice to be evidence informed.
Yeah, absolutely. So I'm going to ask you just 2 more questions, and then we'll move on to our other intensivist, Prof. Ricardo Ferreira. So any thoughts on proning spontaneously breathing patients on high flow nasal oxygen or NIV? Yes,
definitely. There's the UK Intensive Care Society has got good guidance on conscious proning, as they call it. We are currently managing patients on oxygen therapy who were having them in oxygen therapy or CPAP, and they're lying prone. I've seen several patients this week who are in their 70s who would have a poor prognosis and basally ventilated, avoid critical care by actually having conscious proning, and just you go and see them, they're lying in their bed and they're actually sleeping. They've got no accessory muscle use, and it seems to improve their oxygenation.
Okay, perfect. What sort of renal support are you providing? So we've heard from across Europe that patients are often being put onto SLED, so slow dialysis, or CPVH. Are you guys using standard dialysis, or what are you doing?
We use, within Earth Health Board, 3 of the units use CPVHF, hemofiltration or hemodiafiltration, and 1 hospital uses intermittent hemodialysis. We are still coping at the moment with regards to having enough hemofiltration machines. If we can see more and more patients, we'll move to timed treatments, and we'll just increase the dose. So, but we're using hemodiafiltration.
Okay, and you wouldn't pass any comment on noticing a difference in terms of outcomes with any of these different options?
But there's certainly in a critically ill population, my experience has been hemofiltration, and that hemodiafiltration is better than intermittent hemodialysis, because you're taking fluid off a longer time. So if that's cardiovascular unstable, the patient tolerates it better. So that would be my thoughts, and that's just my experience over the years. But I know that the hospital does intermittent hemodialysis. It works well in their hands because they've been doing it since I was a trainee. So, and that was the days before hemofiltration, I think. So it works well in their hands, but in my hands, hemodiafiltration continuously would be the way forwards.
Okay, perfect. So just in the interest of time, I think we'll move to our final speaker. So it's Prof. Ricardo Ferreira, who is the Chief of Intensive Care in Barcelona in Spain. See, maybe disappeared, have they? Oh. Prof. Ferreira, can you hear us?
Yes.
Oh, perfect, lovely.
Okay, so I'm going to share my screen.
Fantastic, thank you.
Can you see my presentation?
We can, thanks very much.
Okay, so maybe we can discuss about the treatment in the questions and answer, because I'm going to discuss more about how we have organized care of COVID patients in more in a logistic way.
Okay.
So I don't know if my presentation is still there.
So is there now? Yeah, if you just make a presentation, that'd be
okay.
Perfect.
Okay. So this is the current situation in Spain. We have yesterday 1,072 cases, 1,000 cases, and 18 deaths. You can see here in the slide that Spain is leading Europe in terms of cases and also in terms of deaths, because we are a little bit ahead of 2 weeks or 1 week or 2 weeks ahead behind Italy. So according to this data, probably we are going to be above Italy in few days. So the lockdown in Spain was down the 13th of March, and you can see here this is the number of patients in the ICU. We have 250 patients in the ICU in that moment, and maybe it was too late for the lockdown when you have such amount of patients in the Spanish ICUs. This is for Madrid and this is for Catalonia. Patients are 1/3 in Madrid, 1/3 in Catalonia, and the rest are spread across the country. So for that, we have to expand the ICUs to 300%, which was a logistic challenge. We have a hospital in Madrid in the convention center, and we have been planning another hospital, another ICU, in fact, in the convention center here in Barcelona, but it was just a project and hopefully was not needed at the end. This is the distribution in Spain, mostly in Madrid and in Catalonia, and less in the other areas of Spain. This is for cases, this is for deaths. And again, you can see that the distribution is heterogeneous, and because of the state of alarm, it's the central government who is taking care of the healthcare system at this moment, not the communities, which is which is normal. But in fact, there were no cases moving from communities with a lot of cases to other communities with less cases, or professionals or equipment moving from low cases to high cases. So this is again something that we have to learn when you have heterogeneity, that I think it's quite common in many countries. It's interesting that you can move patients, which I do not prefer that, or to move equipment or professionals, which I think is the best option if you have heterogeneity. This is for Catalonia. This is the number of ICU beds before the pandemics. This is our standard. This is the capacity we can get using normal ICU bed, and this is the capacity we got at the peak of the pandemics, expanding the ICUs to another areas of the hospital not ICU, real ICU beds. Instead were ICU spaces that were just prepared as temporary ICUs for the pandemic. So this is the forced capacity that was done using, for example, not ICU ventilators. So again, this is Catalonia. These are 28 hospitals in Catalonia, and this is the percentage of ICU ventilators according to the number of patients. Some of them are well equipped in the areas where the incidence is low. More than 100% of the patients could have an ICU ventilator, but you can see here that some hospitals, like this one here, only 25% of the patients has been ventilated using an ICU ventilator. The rest of the patients are using have been ventilated using operating room ventilators, non-invasive ventilator adapted for invasive ventilation, or transport ventilator, which of course is suboptimal. These are some of the prototypes that has been developed for these pandemics. This one was made by also an ICU team. This one here was made by the SEAT factory, the car factory was made. But of course, these prototypes are not adequate for ventilating patients and has been used just as the backups, or in some cases of compassionate use, just to evaluate these prototypes. So at this stage, we have more than 10,000 healthcare workers infected by COVID-19, which is more than Italy and in China. We are in the discussion if being a healthcare worker in Spain is a risk factor. I am not very convinced about that, because we are only testing patients admitted in hospital and healthcare workers. So this is maybe because the small denominators maybe can magnify that. But it's true that some lay people consider us like heroes, and they are applauding every night at 8 p.m. to us. But really, we are not heroes, of course. We are just healthcare workers, very committed to try to improve the situation, despite we have some limitations like in many countries. So training is very important for trying to prevent the infection of healthcare workers, and we have provide training for, of course, new workers less experienced than us that are coming to ICUs, nurses and doctors from other areas of the hospitals that should help us or are helping us, and we provide training for that. Also, it's very important to identify the main roles at the beginning of the day, who is going to intubate that patient, who is going to do CPR, to try to avoid infection during emergency situations. And of course, the rational use of PPEs, because sometimes during these pandemics, we have a shortage of PPEs also that we need to manage. And also it's very important to prevent moral distress when maybe you are dealing with the last ICU bed and you have some patients to admit, and sometimes you have to take tough decisions during this pandemic in Spain. This is from the Spanish Society of Intensive Care, which I am the president right now, and we provide during this pandemic a lot of materials that I think that could be useful for you, especially for those who can read in Spanish, because we prepare an interesting contingency plan for the country that has been useful for many hospitals that arrive later to the pandemics. And of course, an important document about the ethical decisions, how to take these ethical decisions during the pandemic, that has been the base for many protocols in many hospitals in Spain, and some recommendation of our working group. And we are doing, like you, we are doing every week teleconferences with the heads of department across Spain to understand how is the pandemic. But now we are also preparing webinars every week to update our members and our clinicians in the treatment of this condition. This is the example of my hospital, Vall d'Hebron Hospital in Barcelona. So this is the ICU expansion. We move to 13 areas in 3 different buildings. So this is a big challenge. As I told you, some of the areas are natural areas, so you can grow to a post-surgical ICU because you stop the surgical program. But sometimes you have to move to these new areas. You know, these are temporary ICUs that we built in this white space, which is much more efficient in terms of treating all patients with the same condition and with the same, the same infection, so it's not problem to cross-contamination, and you can work with the PPEs, with the same PPEs for managing all patients, and the management of the PPEs is also much more efficient. Of course, you have to find some spaces for resting, and of course, you have to organize shifts, because working with the PPEs is quite hard. But we manage for doing that in all these 13 spaces we have found across the hospital. So at the end, we have more than 200 ICU beds across the hospital in these three buildings. So this is the pandemics in my hospitals. We have the first case at the beginning of March. This is the lockdown when we have already treated 20 patients in my ICU, and this is the daily number of patients. We have the peak of 25 patients per day in the ICU. That means an intubation every hour. So this was very tough, and we have that for 3-4 days with around 20-25 intubation per hour. And this is the number of beds of patients admitted in the ICU. You can see the slope is vertical, and then we have the plateau here starting the second week of April. And by now we are decreasing the number of cases we have in the ICU, and also, of course, the new cases we are attending every day in the ICU. We are attending 4 or 5 patients of COVID patients in the ICU new admissions, 4 or 5 patients per day now in the ICU, but the balance between patients admitted and discharges from the ICU now is going in favor of discharges. In red, you have the number of patients needing ECMO. We are an ECMO center, and you can see here that the peak of admissions were here, the peak of patients in the ICU, the peak was here, the plateau was here, but we have not arrived to the peak for ECMO patients. So ECMO patients came later, and we are still admitting today. We are admitting 2 extra patients needing ECMO in my ICU. We are going to have 10 patients in ECMO at this moment in my department, because those patients are being admitted because pulmonary embolism or lung infections in the context of the RDS and the thrombotic state that have those patients. So we expect that next week we are going to have the plateau and the peak and the plateau of ECMO patients in our area. The number of patients needing hemofiltration is 6.6% of the patients that we have admitted in the ICU. This is the mortality rate. So this is the group ages. So we have patients in every group. Of course, we have more than 300 patients by now attended in our ICU. You can see here that the mortality, the orange part are the patients still admitted in the ICU. The red are the death, the green are the patients who have been discharged. So mortality below 60 years is really, really very low at this stage. Above 60 years, it's around 35%, and above 70 years, it's close to 60% mortality in patients admitted in the ICU. And the mean stay for discharges is 10 days, for deaths are 11 days, but patients still admitted in the ICU, mean stage at this moment is 14, so this is sure going to increase, and the mean stage is going to be close to 3 weeks for patients admitted in the ICU. So we are using also hemoperfusion. We have treated 5 patients with some type of hemoperfusion, mainly cytosorb or oxiris, and we are doing that in patients with high IL-6 levels above 1,000, and also high levels of D-dimers above 1,500 and ferritin above 500. If patients have this inflammatory and procoagulated state and they have severe respiratory failure, we are doing these hemoperfusion therapies in those patients. I cannot show you data because it's only 5 patients, but we have the sensation, at least the sensation, the impression that these patients stop needing prone position, or they can reduce the number of prone positions that after the hemoperfusion technique. Of course, we have a nice correlation between IL-6 levels and mortality, and the main limitations for that are clotting of the system, despite we are using citrate, and in some cases we are adding heparin to the patient. And another tip is that sometimes the levels of IL-6 are difficult to interpret especially when you're treating patients with monoclonal antibodies and anti-IL-6. For this expansion of the ICU, we need a lot of another teams. This is a different, like in China, for example, that they have intensivists of the time that are doing shifts with intensivists coming from other areas of the country. Here in Spain, we couldn't do that. So what we are doing is that we are doing shifts with the leadership of an intensivist together with an anesthetist and with another professionals that are not working in ICUs usually, but we are training that and helping them to work in the ICUs. And we have some examples of traumatologists, for example, doing prone positions in the ICU, helping for the prone positions. Psychiatrists of the hospital, they have a nice team giving psychological support to intensivists and nurses, and also surgeons doing the tracheostomies. You have to take into account that each single day we have between 5 and 10 tracheostomies in my department in some moment of the pandemic, so we need some help for that. And also we have residents from other specialties that are helping that to give telephonic information to families. So in this moment, we don't allow families to come to visit patients, any patient in the hospital. So information is always by phone, and sometimes we have residents helping us to asking for consent, for example, for trials, or asking for consent for tracheostomy, and we are doing that by phone. For coordination of 200 beds in the same hospital in different areas of the hospital, we are doing like now Zoom teleconference with all the coordinators. I have seven coordinators that we need to talk every day, and especially we are discussing therapeutic ceiling of some patients, and we are taking this decision patient by patient and by consensus. And this is important that we have this teleconference every day to discuss the therapeutic ceiling of some patients. And also every week we are doing a webinar to the 200 doctors that are taking care of the ICU patients every day. So our contingency plan in my hospital, we have to expand, as I told you, the number of ventilators, and sometimes there are suboptimal ventilators. We have to increase the ECMO devices from 3 to close to 10 now. We have 10 ECMO devices now to afford the number of ECMO runs we are doing. And also we expand the hemofilters. We have been working with some data coming from China saying that up to 30% of the patients are going to need hemofiltration. So we expand the number of hemofilters, or we calculate the number of hemofilters we're going to do when they are close to 20. But at this moment, we are not needing such amount of hemofilters. The management of disposables and pharmacy is also something that those people that are still in the early phase of the pandemic need to know, that this is again a challenge, because we almost run out disposable for tracheostomy, for bronchoscopy, from equipment for mechanical ventilators. So the amount of consumption is very high, and it's difficult to find in the market some of these disposables and some of these pharmaceutical products also. Also, interesting strategy is that we have been using hotels. You know that Spain is very strong on that. We have a lot of hotels. We are a touristic country. So we have using the hotels for healthcare workers if they need to rest and they have concern about infecting patients, infecting families at home, especially if they live with old people. So we have the possibility to rest in hotels, but also some of the areas of the hotel are COVID areas, and we are discharging patients that at the same time cannot come back home because they are living and they cannot be isolated at home because they are living with other people and the rest of the family, so they can keep the isolation in the hotel. So in the hotel which is close to the hospital, we have COVID and non-COVID areas for patients and healthcare workers. And also we have expanded the hospital to the sport pavilion, which is just in front of the hospital, also for discharging patients. Some information about clinical trials. We are participating in these 4 clinical trials, some of them in antivirals, some of them in monoclonal antibodies against inflammatory mediators. And we are starting this week the trial with convalescent plasma in patients with COVID-19 pneumonia. So my learning points of these last weeks is that this infection is a devastating condition. It's very simplistic saying that this patient can improve with just a ventilator. RDS is quite severe. Those patients with RDS by COVID-19 need mechanical ventilation, prone position very often. Secretion, especially secretions are very thick, and we have secretion plugging very often. So humidification of the system, frequent bronchoscopy to aspiration of secretion is needed. And if you have such amount of patients, maybe you're going to need 8 or 10 bronchoscopies per day. AKI, of course, is common, close to 30%. In our case, 6.6% needing hemofiltration. Myopathy after extubation is very frequent, and rehabilitation is going to be needed in many patients discharged from the ICU. Bacterial co-infection is uncommon. Some patients have this hyperinflammatory state. That's why we are using hemoperfusion in some patients. But on the other side, we have some patients with immunoparalysis. So CMV reactivation and fungal infection is not uncommon. But I think that there are some confusing factors because many patients have received tocilizumab or have received steroids in the ward, sometimes high dose. And this could be a confusing factor and could be maybe more the treatments that the viral infection, but itself that makes that CMV reactivates or infection by aspergillosis. So mucus plugging and bioethical dysfunction is part of our learning points. So sorry. So another important measures is you are in the early phase, just prepare national contingency plans. We need a strong health governance in our countries that allow to move patients or move professionals. Definition of case is another thing we have to learn from this pandemic, that we have been working with a definition of case at the beginning. Only patients coming from Lombardy or China are considering cases, and we cannot do PCR in those patients not coming from this area, and that makes that patients isolation of patients have some delay, and this was another mistake we have at the beginning of the pandemics. And I think it's important to understand the community circulation of the virus is everywhere, and we should work with syndromic radiological syndromes more than waiting for PCR tests to confirm the diagnosis, because in these days, those patients with the typical X-ray are those patients who have the diagnosis. We don't need to wait for the PCR to start isolation and therapy and support in these patients. I think it's important to establish a common criteria for ICU admission, for invasive mechanical ventilation, and for ECMO. If you are working in a close area in your country, it's important to share these criteria and to have common criteria in terms of give the same therapy to all patients that need these treatments. So I would like to finish saying thank you to this team. This team is a team of coordinator in my 11 ICUs, and also the nurse coordinators and the nurse supervisors of this area. I think they have a nice teamwork. There are some retired doctors in this photograph, because we asked retired doctors to come back, and they are helping us with non-COVID patients, and they are coming back to the hospital to work. And this is a very good support, because they are very experienced doctors. So they have vocation and compromise coordination, and with these webinars, we are updating all the information. Thank you to you also for your attention.
Thank you very much. That's another fantastic talk and a great summary of what's been happening. So I'm aware that time is ticking on, so I'm going to quickly ask you just a couple of questions, and then we'll draw things to a close. So we're being asked, so Kevin and Ricardo, do you have any experience with CytoSorb for cytokine absorption? Have you been using that in intensive care?
So we have been using CytoSorb in the situation I mentioned. So patients with high inflammation, activation of coagulation, and severe respiratory failure.
And how many?
Of course, this is not evidence-based.
Yeah.
And of course, it's very difficult to draw conclusion for 5 patients.
Yeah.
But we think that there is a rationale for doing that, and we are doing that in this small group of patients. I insist that this is less than 1% of the patients we have been treating in the ICU.
Okay. What levels of CPK or creatinine kinase elevation have you been seeing? There's been a suggestion that some of these patients have evidence of rhabdomyolysis, presumably because of the temperature. Have you seen that, or?
We have CPK levels high in some patients, and also high levels of troponin. So elevated troponin is in patients in the ICU, despite they are not in shock, despite they are not with hypoperfusion. So this could be myocarditis. We have some patients with levels above 2,000 of troponin, and some patients, of course, also with have level of CPK.
Kevin, have you seen that?
We've seen lots of patients with elevated troponins, a few high CKs, but nothing to write home about, and certainly not. I don't think that's a cause of the renal failure.
No. Okay.
Yeah, they are not contributing to renal failure. I fully agree.
Me too. Okay, and then what about patients with end-stage renal disease? Have you treated any in intensive care, either in Paisley or in Spain? So patients already on dialysis?
Yes, we have patients with dialysis, and we have patients with renal transplant also in the ICU with COVID-19 pneumonia. And of course, we are admitting these patients, especially if they are above 70 years, but I cannot say anything. We are admitting them, and we are treating patients with renal transplant and chronic kidney injury in the ICU. But I cannot send any message because the number is, of course, is small. I think 2 patients with renal transplant and 2 or 3 patients with chronic kidney injury.
Okay, can you had any? I don't think so.
No, certainly the UK data is about 2% of patients with kind of end-stage renal disease, and we haven't seen any within our hospital. I presume they probably go to the Queen Elizabeth, and I don't know if they've had any yet.
So I know they've had a couple of transplant patients, but I don't think that they've had any of our renal replacement or our dialysis patients. Okay, so the very last question, Ali, you get the honour of asking or answering, sorry, the last question. So Annette Brookfield is asking about the use of SGLT2 inhibitors in nephrotic patients.
Thanks for sparing that for the last thing. It's a great question. I think it goes in the same line of ACE and ARB inhibitor. I think if one is the complete purist in doing evidence-based medicine, so to speak, I think there are very many people are critical of targeting proteinuria as an endpoint for patient with kidney disease. And then again back to what initially was discussed is even if we would be targeting proteinuria as an endpoint, the benefits are not immediate. We would more look long-term benefit over months to years for preservation of renal function. I think there is definitely a study of SGLT2 inhibitor in FSGS by Canadian colleagues, so we will see that. And I would foresee, and that's my personal opinion, that in a few years we will be routinely using it for non-diabetic kidney disease, proteinuria kidney disease. Pertinent to acute COVID-related issues, I think I wouldn't be compelled to go one way or the other. Like in the sense of replacing ACE inhibitors with SGLT2 inhibitor, I probably would not do that.
Okay, so thank you. So I think it's testament to how great a session this has been that it's gone on for so long. So I'm sorry we've taken up so much of our time, but I think everything that the 4 panelists have contributed, so Kevin, Ali, Swap and Ricardo, thank you very, very much. That's been very informative. Again, this will be available online probably on Monday. So if you want to refresh any of it or pass it on to your colleagues, please do. And have a good weekend. Thank you very, very much.
Thank you.
Thank you. Have a weekend.